Hello, everybody. I'm Cristina Dalmeida, the Scientific Director at MedExprime. Today, I would like to share some experiences about the ideation of a project that we have submitted to Horizon Europe on virtual twins and that had just been the laureate in April of this year. So MedExprime has been involved in European projects for quite a while, since 2018. We have participated as a member, as a technical coordinator in Chameleon project, and this was a very good experience taking for the coordination now for a liver heart virtual twin project that we have just submitted. So before we go ahead, I would like to just make a slide of a very touch two words on the difference of virtual and digital twins, because not really clear in the literature. So simply put, digital twin would be really the representation, the 3D representation of something that exists in the real world. It can be an object, it can be a process, which is largely used in industry, it can be an organization or even an individual. The idea here is to mimic physical characteristics or even behavior. And another thing that is very distinctive of digital twins is that it's really dependent upon continuous collect of data by means of connectivity. So our project focuses pretty much on virtual twins, which is a more sophisticated, developed model. And the object here is to model full systems. So when I say about systems, it's about diseases. And in terms of health, we're talking about pathophysiology. That is to say, how it works, how the disease happens, and how it evolves, how does it progress. It's not always linked to real-time data, but it's fully intensive based on multimodal data at different scales. It can be from an organ level, a tissue level, cellular, or even subcellular level. And of course, the use in healthcare is to promote precision medicine in different states. So the project here is pretty much focused on the constitution of a decision-aid clinical tool to help doctors to better, to improve the healthcare of different diseases, concerned chronic liver diseases and different endpoints. So the 4 use cases that you're going to focus on the project will pretty much represent the 4 different endpoints. The first one will constitute the understanding how is the progression of fibrosis in MAFLD patients. The second one is whether there is or not a relationship between heart fibrosis and liver fibrosis. This is pretty much a research question. The third one will be focused on patients more advanced suffering from cirrhosis, and there is an intervention that is designated for portal heart palpitations, the placement of chips. It's a kind of shunt. There is a lot of cardiovascular complications, and the virtual team will try to respond to early diagnosis, what would be the cardiac complications related to this population. And the fourth one is the last stage, the end point, with patients suffering from hepatocellular carcinomas, and you try to understand what are the cardiovascular complications derived from any kind of treatments for this population. We have a very consequent consortium here, as you might expect. We have 9 countries, 7 in Europe, 21 partners, half of which are university hospitals. So one of the objectives in this project is to fill in the gaps in the state of the art. Please do not underestimate this very time-consuming but essential step for the organization of the European call. We are very surprised to see how many initiatives are already on the way in the development of liver virtual twin models. So most of them are financed by Europe, some in France here, and another clinical axis of the project was as well the metabolic origin of the chronic liver diseases. These 2 state-of-the-art were really essential for us to determining what will be the best partners, academic and clinical ones, as well as patient associations. As for the technical standpoint, MedExprime also participates in 2 European projects, which are Chameleon and UK. Both are focused on health data and the architecture of federated infrastructures. And we also identify 3 European projects on model and development and standardization, which is crucial for the development of our cohort. Another thing that I would like to undercase here is that the consortium is really dichotomized. It's really a constitute of 2 legs. I think one leg would be the clinical leg, and the other one would be the modeler's leg, the computational modeler's leg. So they pretty much see the same thing in very different standpoints. So the clinicians, for instance, if you take the first case, they're going to ask questions like, what is the risk of a progression? What are the mechanisms of the progression? How fast does it go? Of course, they are focusing on the healthcare, on the patient. But modelers, they are much more concerned about what is the computational approach that I can use? Can I integrate AI and mechanistic models? What are the suitable signatures? Do they exist? Do we have to find them? What is the best approach to be done? It is reliable follow-up. So if you analyze all the clinical cases you're going to see here, of course, the heterogeneity of these questions will be much larger. And this is where I think the SMEs and PMEs like ours can play a really significant role as facilitators to provide a coherent discourse and to understand what are the both sides and to project and to prepare a project. So don't be afraid to be a coordinator. So what is the cornerstone of the virtual twin? Well, it's pretty much what MedExprime does is the establishment of a regulatory grade cohort. Of course, we have to comply to GDPR. It has to be fair, and of course, longitudinal. What I'd like to call attention here is that instead, in addition to identifying the clinical cases here, which in the case is MAFLD in the cardiomyopathy, we have to be representative. Representativeness has to be assured both at the individual and populational levels. For the individual level, we have the multimodal data set here. That's what we call a patient 360 degrees that will constitute the multimodal data. So we can have imaging, biology, clinical, genomics. But of course, the left part of the scheme here is very important to decide which are the subpopulations that you need to identify. And I will call attention to this little word here, which is the follow-up period. Follow-up period will be essential for you to identify what will be your clinical partners and how many of them you have to require in order to promote a feasible cohort that can be representative. In terms of developing of the twin, for the 5 groups that I have just mentioned, we have the broader stage, which will be the cluster and pattern identification. This is pretty much made with retrospective data, but as we define more and more specific clinical questions, we need to introduce specific inclusion criteria which might be restrictive, and then we have to move a little bit further on the regulation, going to prospective data. The approach that you have for the development of these models is quite bold, ambitious. We decided to have a parallel approach in submodels development. The first one at different scales in the organ, the tissue, the cellular, and subcellular, at the same time focus on different organs. And by different organs, I mean liver, heart, but also the hemodynamic system. Of course, they will be individually developed and associated, and then try to be integrated in case specifics in the R&D settings. This will be pretty much the most time-consuming step here of the project. They'll be quite retroactive, but when they are sufficiently matured, they're going to be visualized by means of a clinical decision support system that MedExprime is going to develop and try to make it the most user-friendly as possible and see whether or not it can be integrated in the workflow, in the clinical workflow. I cannot go into detail here, but of course the evaluation methodology will take a strong part in this project and will be organized in 3 different steps. The first one is regarding the submodels individually and associated, of course with the data of the cohort that will develop these models. There will be a verification validation step with a different set of data concerning the 5 subgroups, and finally have an observation study in a different setting to see whether the clinical decision support system is integrated in the routine care. So the 4 topics that you want to raise, the 4 results in routine care that you would like to find is, first of all, patient certification to really identify the most eligible patients for different interventions. The second will be the early detection of the endpoints of the disease to improve therapeutic decision. But of course, there is a very strong social component here, which will be, first one, the training of the young clinicians, as well as to facilitate the communication between patients and doctors so they can better understand what is going on with them. So quickly, if I can take some takeaways, data quality plus, plus, plus. I think there's nothing that's never too much to remember that the quality of the data is crucial, but not only quality, but representativeness. The feasibility is extremely important, so follow-up time, please take in consideration. Do not overestimate the state of the art. This is essential. The sky's the limit, but keep feet on the ground. So don't be too ambitious. That's one of the most problems we have in our consortium. All things matter, so don't overlook any details of a European call. This is what was another important issue in our consortium. Right balance of the consortium members, mostly identifying the state of the art, not the ones you want to work with. And SMEs and PMEs as being a very good facilitator in this kind of projects. So stay tuned. If you want to flash our QR code, we'll be more than happy to share more information with you. And the kickoff day will take place in early February, so stay tuned. Thank you so much.